Hi, I'm Scott Miller. I am a therapist, a researcher, a trainer, and a consultant. I'm also the director of the International Center for Clinical Excellence. This is the largest web-based community of mental health professionals on the planet. Started back in 2009, a small group of behavioral health practitioners got together at the Evolution of Psychotherapy conference. We had a common interest. We really wanted to improve our outcomes. We wanted to have a place where we could meet and discuss our work behind a firewall, ask questions, and really talk about the nitty-gritty, the difficult challenges that we all face on a day-to-day basis. That platform has now grown to tens of thousands of members. It's a place where you can go and meet fellow professionals and talk about the work that you're doing on a day-to-day basis with your clients. Every once in a while, I meet some professional who gives me pause. It makes me wonder why are they in the field? But that is truly the exception. Mental health professionals are kind, knowledgeable, and helpful people. And what usually strikes me is the purpose that they share in common, the strong desire they have to help the people who cross their threshold and come to see them about the challenges that they're facing in their life. What's amazing about clinicians is how they maintain this hope in the face of the challenges that clients bring into their offices. Our particular website is a platform, a network. It's entirely free, where clinicians can get together and discuss their work, ask questions, and access resources about improving the outcome of their work. So with all of the challenges that our clients face and the challenges that we face as practitioners, I think it can be very easy to lose focus on why we're all in this business, what got us into the field in the first place. So I wonder, how did you feel when you first started working with clients? I was amazed and often overwhelmed by my clients. Their resilience was inspiring. Their challenges were simply too much at times to bear, even as a therapist. At the same time, I was also shocked that they trusted me. Here was somebody straight out of graduate school. I really didn't know what I was doing. I had 3 or 4 things that I said over and over again. What I hear you saying is, and so you must be feeling this or that or the other thing. I can remember praying during my practicums that the time would go by quickly so that they wouldn't figure out that I didn't know what I was doing. But then, as now, I was troubled by several things. The first one was when clients just stopped coming. They just stopped showing up. I was surprised and shocked, and I also found that the explanations that my supervisors and professors sometimes offered really didn't leave me feeling satisfied. Yes, it was fine to say that the clients weren't doing that well, or that their pathology had gotten in the way or tempted them to think that they could do it on their own. But really, I thought maybe it had something to do with me. Maybe it was a skill that I might be missing. In any event, I wanted to figure out how could I improve. Then there were other clients, again, then as now, who no matter what I did, how many books I read, how much supervision I got, just didn't seem to get better. These were clients that stuck in my mind, that when I drove home from the office, I reflected, and they went around and around in my head, small snippets of conversation that I wished I could redo, that I thought if I did or were able to redo them, the client might return, magically somehow get better. Those times I was left feeling lost in the woods, not sure what to do or where to go. I mostly kept that to myself. I didn't say it to others who seemed to have really great outcomes, at least in the stories that they told. So something happened when I was a young therapist. I received a job offer from 2 very well-known clinicians working in the Midwest. Some of you may know them, Steve DeShazer and Insoo Berg of solution-focused brief therapy fame. I couldn't believe it when I got the letter telling me that they wanted me to come and work in Milwaukee. I'm not talking just about working part-time, being a full-time member of the faculty. Here I was still feeling like I didn't really know what I was doing, and they were asking me to come and work with them. It was an amazing, heady experience. I sat behind a mirror and watched thousands of hours of work being done by 2 expert clinicians. And I have to tell you that during that particular time, I became a much more confident clinician. Gone was my inability to articulate what I was doing at each and every moment of the session. I was much more certain, and there wasn't much that a client could say that I hadn't heard before and didn't know how to respond to. Then something happened. After I'd been at the Brief Family Therapy Center in Milwaukee, Wisconsin for about 5 years, we asked some researchers to come in and evaluate our work. We'd been claiming that we were not only more effective, but that we accomplished our objectives with a shorter period of time. 1 session on occasion, but no more than a handful of visits. The researchers came in, they did their work, recontacting about 250 of our former clients, doing thick interviews, as well as administering some standardized scales. I'll never forget the day when they came to report on their particular findings. They asked me, did I want to hear the good news or the bad news? Well, I thought, well, what could the bad news be? So tell me what the good news was. They said, you're effective. What you are all doing here at the Brief Family Therapy Center really does work. Well, what could the bad news be, I wondered. Well, they said, you're not more effective than anyone else, and you're not doing it more briefly than anybody else. It was a big shock. It rocked the team. And within a short period of time after that, the team split apart. How could I teach a model of therapy that was as effective as everything else? For me, this sent me back to the research literature. I really wanted to know, how could I get better at what I did? I had become a much more confident clinician, but the truth was, I wasn't any more effective than I was as a student or prior to being at the Brief Family Therapy Center. When I looked at the research together with my colleagues about what works in therapy, here's what I discovered. About 50% of the people who start in treatment, regardless of the method and regardless of the problem that they present with, end therapy abruptly. That is, they discontinue without warning. Half of those who discontinue, in case you're wondering, have experienced no benefit from treatment whatsoever. That was a deep concern, and it wasn't just about my work or the work that we were doing at the Brief Family Therapy Center. It was true of all clients who entered treatment. Here's something else we know from the research literature that the team found when reviewing the evidence. Of those who do continue in therapy, a staggering 35 to 45% of those people experience no measurable benefit from the care, despite how long they may go in treatment. Now, I know that that may not add up to your personal experience, but I'm talking about the research, people who've carefully measured the results and followed clients over time. Here's another piece. It's surprising that the research indicates that our view of the therapy is often at odds with our clients. We may think we have a great relationship, but the clients simply disappear. And when we follow up and we ask them, in fact, one of the primary reasons they give is that the therapist just didn't get me. They didn't seem to understand what I wanted or were willing to work on what I wanted. Outside of all of those concerns, that is, the people who come and drop out, the people who come and don't drop out, they stay, but they don't experience any benefit. There's one very large and recurring problem in our field. Despite being on the scene for over 150 years, going all the way back to Freud, the truth is the majority of people who could benefit from our services, they never make it into a therapist's office. The figure, if you're willing to hear it, is between 80 and 85%. Take a moment and think about that. I know as a caring, thoughtful mental health professional, it will bug you as it does me. 80 to 85% of the people who have concerns that could be helped by seeing a therapist choose not to go. So the question is why? And this is a time to talk about it because it turns out that in looking at large demographic studies, fewer and fewer people are actually turning to psychotherapy to help with their problems. In fact, about 33% less than did 20 years ago. Now, I know what you might be thinking. You're thinking that, wait a minute, I have a waiting list, or my caseload is full, or the agency can't take any more clients. To me, that's a little bit like saying that there's no such thing as global warming because it's cold at your house. The truth is that when we step back and we look at large national samples, fewer people are turning to psychotherapy to solve their problems. Now, that's not necessarily a bad thing. People are doing other things. They're joining gyms, they are seeking out support from their friends, they're going to church, etc. But we are uniquely trained to help people with those problems, and it's sad that for some reason they don't end up in our offices. Well, at the same time, one of the other things people are doing is turning to medication. Curiously, when you ask people, would they rather talk to somebody about their problems or take a pill? And when I'm teaching about this in workshops, I often ask people to vote. What do they think? Would people rather take a pill or would they rather talk about it? And therapists, that is, talk professionals, say that they think people would rather take a pill. They're surprised when I say it's the reverse. Most people, upwards of 75%, would rather talk about their problems than take a pill. I know, I'm painting kind of a bleak picture of psychotherapy, and you may want to just go back in your office, shut your door, and meet with your clients. But despite all of these difficulties and troubles, I'm hopeful because I think the research literature is clear. Therapy works, and when it works amazingly well. Let me give you one other factoid. Psychological treatment of any kind that's been tested in a randomized clinical trial with any particular diagnosis or presenting concern of a client is as effective, has the same effect size as coronary artery bypass surgery. And I sometimes say in my workshops, the cool part is therapists leave fewer scars, and they hardly kill anybody they work with. What we offer is really helpful to people. So the question really is, how can we improve our outcomes? How can we get more people into care? And about 20 years ago, my colleagues and I were struggling with these questions. We knew that the particular brand of therapy that a therapist used really didn't predict how effective they were. Neither did their licensure or their background or training. Attending conferences, earning your CEUs, none of these things seem to be predictive of outcome. Neither is therapist experience. I know that's hard to believe, but that's essentially what the data have said for the last 30 years. Being an experienced therapist confers no advantage in terms of outcomes. So our colleagues struggled with this because personally, that's what I wanted. I wanted to be a more effective practitioner. How could I do that? If going to workshops, if getting training, if getting supervision, none of that stuff seemed to make a big impact on my outcomes. So we gave up. We thought maybe we never can figure out how to be more effective, but here's what we could do. We could measure our outcomes and figure out when we were effective or not. Maybe by identifying those clients we didn't help, we could develop more strategies, we could focus more time and effort on those particular cases. We developed two very simple scales, one called the outcome rating scale and the other called the session rating scale. By the way, both of those scales are available for free on my website at www.scottdmiller.com. Look to the left, find the icon that says Fit Measures Licensing, and if you're an independent practitioner, you can download the scales and begin using them in your work. By the way, they're available in 30 different languages. FIT, or feedback-informed care, is the clinical process used to describe monitoring the outcome of the work that you do on a session-by-session basis, and also checking in with clients about the relationship that you have. And clinicians say, and the research backs them up, that using these two simple scales actually helps them identify those failing cases, giving them the time that they need to take effective corrective action. The research to date, and we have over 20 randomized controlled trials, shows that simply asking clients for that kind of feedback. Have you made progress since the last visit? What was your experience of our conversation today? Reduces dropout rates by 1/3 and improves outcomes by nearly doubling the effect size of treatment. As I say, numerous studies have confirmed these findings. FIT, or feedback-informed care, is what's helped me maintain my hope in the face of the difficult challenges that my clients face, as well as all of the regulatory and bureaucratic nonsense that goes on in our field that makes me fill out paperwork that really makes no difference in the day-to-day clinical work. Using these two simple scales, backed up by multiple randomized controlled trials, really helps me feel like I'm doing better clinical work. It's more than a feeling, actually. I can actually look at my data on an ongoing basis and show that year after year and from client to client, I'm achieving better results. So in my next video or communication, I'm going to be talking more about FIT, how you can use the measures in greater detail to achieve superior results in your work. Meanwhile, I'd like to invite you to do a couple of things. As I already mentioned, please feel free to go to my website at scottdmiller.com. Look to the left, find the icon that says Fit Measures Licensing, click on the link, fill out the brief form, download the tools, and just start using them. The best way to do it is to jump in. The second thing I'd like to invite you to do is join the ICCE. That is, again, the International Center for Clinical Excellence. It's free. It costs nothing. You're not going to get unsolicited ads and emails in your inbox soliciting you to purchase books or join webinars or anything of the sort. Instead, it's a place where you can go behind a firewall and talk to colleagues. You can always email me. I respond to all of my own emails. Sometimes it'll take me a day or two to get back to you because I'm on the road quite often, as I said in the beginning of this particular video, but I will respond. If you don't get an email from me, then please check the email address and make sure that the D is in between Scott and Miller, info@scottdmiller.com. I look forward to talking to you next time.